I'm here today with my friend, Dr. Brent Lang, a urogynecologist. He has delivered more than 7,000 children, and he was a guy with a problem. And he said, well, gosh darn it, we need a better way. Dr. Lang.
Good morning. Thank you, Joe. Hope everyone is safe and well in these trying times. The intent of today is to give you an idea of the current state of remote patient monitoring as it applies to the field of urology and urogynecology. Okay. Well, you recognize Joe here. This is taken in Carter County, Tennessee. This is the foothills of the Appalachian Mountains. And this is the hospital in the background that brought me to Tennessee. I helped design the hospital, and I set up the entire women's health division of that. Joe asked me a question as we were walking around the parking lot. We were down there doing some filming. And he said, why did you do this? Why did you spend 6 years and millions of dollars to develop the CarePath system? It comes down to a simple need in practice. Urogynecologists spend all of their day dealing with people who have bladder dysfunction. That's the role of the subspecialty. You start off as a gynecologist, you take extra training over many years, and then you function to take care of those people who have bladder dysfunction. The number one piece of information, the critical element in the ability to diagnose and manage these patients is I have to know what her bladder function is, or his bladder function is, when I start. It's much the same as if I was an internist treating a diabetic. Without a clear, accurate blood sugar, I have no idea what I'm doing in terms of managing their diabetes. And the same thing happens here. And the way we do that is we get a clear picture of their voiding history. That voiding data is obtained through two methods currently. One's a voiding diary, which is a 3-day record of their intake and output. And then one is a Uroflow, which tells me how they're able to void. Is there evidence of obstruction? Little medical background. When I'm talking about patients with LUTS, I'm talking about people who suffer from lower urinary tract symptoms. And that's a group of symptoms. That is people who have frequency. They're going too much. They're urgent, meaning that you don't just say, I got to go to the bathroom, I'll find a bathroom next 10 minutes. You're sitting in an important meeting and you get up and you run and hope you make it. That's urgency. Nocturia is when I go at night. You know, I'm up and down 3 or 4 times a night. Urgent continence obviously is I can't get to the bathroom fast enough and I become incontinent. Or issues of retention, problems in obstruction or voiding. To give you some idea of how big a problem this is, in the US alone, there's 58 million Americans who suffer from LUTS. Now, for those of you, I understand those of you in the audience for the webinar may come from medical device development backgrounds or business backgrounds. So, little look at the market analysis of what this means. You know, we have 16% of the people worldwide who suffer from overactive bladder. Less than half will ever see a doctor about it, and less than 10% of those ever arrive at a proper diagnosis or effective treatment. In men, we're talking BPH. All men at some point face this issue. 70% of men over 60 have some issue with BPH and LUTS. That's over 15 million men in this country suffer from that problem. This is a $13+ billion global LUTS treatment market. That's just treatment. That's not the diagnostic costs or the indirect costs. You know, it's estimated in the US annually, it's an $80 billion spend. And that includes direct and indirect costs. And most of these patients have more than one problem. They may have overactive bladder with BPH. If you look at the numbers involved, it's the largest unmet need in all of healthcare. It dwarfs diabetes, osteoporosis, heart disease, and the impact on their life, what we call quality of life, is significant. Severe untreated LUTS has the same impact on their quality of life as cancer or AIDS does.
Why do you say that?
What's that?
Why do you say that? That sounds extraordinary.
Well, it is really, and you know, if you're getting up 4 or 5 times a night, for instance, you're not sleeping. You suffer from depression. It's affecting your diabetes. It's affecting your weight. It's affecting your blood pressure. If you have to go every 15, 20, 30 minutes, you can't go out. You can't travel. You can't function. You can't even work. For many cases, I've had a number of patients over the years lose their jobs because they couldn't function with their bladder in the workplace. I've had marriages break up, a number of them because they couldn't function in the marriage because of their bladder issues.
Why do only 1 in 2 people bother to seek counsel then?
I think there's a couple of reasons there. I think the reason is for many people, they don't think something can be done about it. there's not a lot of education about it. So they don't understand. They think it's something they must bear, they must suffer with. It's something they have to put up with. I think it's changing. I think that pendulum is swinging. You never saw incontinence pads and products offered on a TV 20 years ago. The topic wasn't even discussed on TV. So we're coming more and more, I think, to people being aware of it. I think if people are more aware of it, they become a little more educated as to there are options for it. And I think we'll see that number who come in and try and get treated for it will go up. The problem is we as healthcare providers haven't been that good about taking care of it. So we don't really, most people will present to the primary care level, and many primary care doctors are not really sure what to do with this problem. So lacking, the technology to make a clear diagnosis, they get sent home with medications that have side effects and get discontinued. And that's why less than 10% are ever properly diagnosed and treated and managed on a long-term basis. I need to tell you what CarePath is, so it makes sense to how it fits into what we call remote patient monitoring. And remote patient monitoring, just to update, is the fact that this is technology designed to obtain data, physiological data on that patient in their remote setting, usually the home or the ambulatory setting. So we can use that information to manage them. So this here is CarePath in use. And it's simply a matter of putting it in a position. It turns on automatically because there's no off-on button on it. It knows where it is. It knows you're holding it, so it turns on. You void through it. The data is collected. It's sent off to the cloud by cellular technology. And in the cloud, we can pull it back and use it for any number of reports. It's really what we used to call in digital cameras point and shoot. This is a brief run through on the system. And basically, it shows the pieces, the components involved in it. We have the handles charging on their charger. We have disposable buckets, we call them, that go onto it. And then there's a phone app for the input part. When you're doing a voiding diary, you need to be able to put in what I drank and what I voided and the circumstances around each void or in incontinence episodes during that time. Patients entered on the system quickly. We'll get their phone number because we send them alerts and texts in the process. We have a selection of study that we can do. We can do an in-office study, a Uroflow it's called. We can do it at home. We can combine the two. We want to know when they wake up because that tells us their nighttime versus their daytime voiding pattern. What she's opening up here is a disposable bucket. This part is used for only one patient. It has a RFID chip in it, so it allows us to know that only one patient uses it. It's used multiple times, but it's not used on different patients for obvious reasons. The system is activated, given to the patient. She's instructed how to use it. We download the voiding diary app onto their smartphone. Now, if you're doing a Uroflow at home, and I'll explain what that is very, very soon, we don't need the app part. That is something a man might come in with BPH and we want to know how he's voiding, and so it doesn't require we know what he's drinking or during the day. So basically, it's just used, rinsed, put back into the handy bag they use to transport it. So it's discreet. They can take it to work. They can take it out shopping. They can take it to work, to dinner, whatever. And then information on each of the voids is entered into the system. So we have an understanding of why they voided and the circumstances around it. Did they leak? Was there incontinence? Did it require them to have some sort of protection? And then how much did they drink? And this is all part of the key elements in a voiding diary. What did you take in and what did you void? Comes back to the office. She checks it in. Each of the devices has a RFID chip and a handle, so each one is unique. We know what it is at all times. She throws away the disposable portion of it. It's cleaned with a cabin wipe. Takes about 10 seconds, put it back on the charger. And that's it. Now I'm going to move on from there. So why is this a big idea? I mean, why is this a big deal? CarePath is the first and only remote patient monitoring system in existence for urology. And this is what we used before. I mean, up until now, right now, people use handwritten voiding diaries, meaning they take a piece of paper and they take state-of-the-art technology, which is this. You can see that. That's called a commode hat. Goes in the commode, and you void into it, and you measure it, and you clean it, put it away, and wait for the next time. Problem is, it's very hard to use this. It confines you to one bathroom, if you would. You're not taking this to work. You're not putting this in your purse or your briefcase and going to work with it or dinner. So it confines that individual to home by their bathroom. Then they got to remember to put it all on paper. If I give out 10 of these in practice, I might get 2 back. And if the 2 I get back, 1 gets filled out by waiting room by memory because she forgot to do it and she doesn't want to show up in the office without it done. So they have no real value to them. My nurse will spend 20 minutes training them how to do it. She'll spend 20 minutes trying to make sense of that 1 or 2 she gets back and try and get information, but that it has some value. So the problem is nobody wants the hat. Nobody follows the instructions, and rarely do we get an accurate report from it. And if I did get lucky and they actually did it at home and they were consistent, that happens sometimes. What I know is when I force them to stay at home and force them to stay near the bathroom, in a completely unnatural situation, that's the result I get on the paper. I want to know, how does their bladder work when they live a normal life, when they go to work, when they go to dinner, when they go out shopping? That's what I want to know, and this can't tell me that. Now we have care path. It's all entered, it's accurate, it's not subjective now. This is objective information. All the depth of the information comes from the device and the input from the app. And I can use that to instantly calculate all of the different parameters I need to understand their bladder function. The real power comes in the fact it's all stored in the cloud. So now I can go back and say, I've been following you for a period of time here, several months, years, whatever. Now I'm able to go back and just pull those reports out instantly. Get the 3 reports I want and get an instant report generated and showing how have they progressed with treatment. That's the real key. That's the key element here in this whole process is I need to know how they're doing. On the paper version of it, with the commode hat, I might get 1 patient every decade that gives me 3 accurate voiding diaries. And then I gotta go back through my record on my computer and try and organize them into some sort of viewpoint. This is instantaneous and tells me exactly what I need to know about that patient's status. The other test that we need to do to figure this out is called a uroflow. You void into some sort of receptacle and it tells us how you're able to void. What kind of volume of urine can you move through that system in some set time? Or do we have obstruction? Is it a very slow flow rate secondary to an enlarged prostate? These devices obviously are expensive and they're complicated and they're not going home with the patient. This is going to work to sit in the bathroom at work, obviously. So these are all done in the office. And the problem with that is people coming in the office are inhibited. It's not a normal environment. They don't feel relaxed. And so what you get 2 to 3 times is we get a study that we can't use. It's insufficient volume. Or we get a study that is enough volume to actually look at, but it's not normal. They're forcing the whole void process, which basically distorts the information and renders it somewhat useless. And that's current technology. This is what you get. Now at home, the difference is I'm taking this home now. I'm going to void every day for 12 days or 14 days. Come back in 2 weeks, see the doctor. I'm going to void when my bladder says I'm ready to go. I'm going to void in my own bathroom where I'm comfortable and relaxed. I'm going to void normally. And of the 12 voids or 14 voids that we get, I can get a range, an idea of how they void in their normal environment. Not just one static value under pressure, but their whole voiding pattern organized on here on a report that tells me exactly how they're doing. And then the power is I can follow them over time and say, look, here's where you began several months ago. We put you onto medication for your prostate. Here's where you are now. We're making progress. It's working. And that kind of feedback is important for the provider, the urologist, to know he's on the right track and doesn't need to change your therapy. It's also important for the patient to understand, I'm getting better. This is helping. I will stay with the medication or the therapy, whatever that is. 90% of patients at 11 months on different types of bladder medications have stopped it. They don't feel it's helping them. They don't think that it's worth the cost or the aggravation of the side effects. This helps in that. So that's what got us to today. That's where we ended up spending 5 years and a tremendous amount of capital to arrive at a system that will allow us to do this, the CarePath system. And we were trying to fill this unmet need in urology and urogynecology. And then somebody got too friendly with a bat halfway around the world, or somebody got careless in the lab in that region. You may never know. But then all of a sudden, COVID-19 becomes a pandemic that sweeps around the globe, and everything's changed. And healthcare has changed forever. And we quickly realized that what began as a quest to fill an unmet need for diagnostic information now took on the element of being a life or death urgency. We needed to keep patients and providers from contacting themselves directly. We need to avoid that patient physician provider contact to avoid infection. We need to be able to deliver healthcare in the urology field without the patient coming to the office any longer. Now, we didn't arrive in time to make a big difference in the first wave. We were running fast and hard to make sure that we're in a position to help with the next wave, and there will be more waves of COVID-19. So that's a story of what brings us here today, and the work we've been doing. Just a bit of quick information you're going to want to know. Yes, we're cleared by FDA. We have a large patent estate. We have 55 patents filed, 33 have been issued. The team that founded and runs Tract has done this before. This is our third effort together. Our last corporate effort was Advanced Uro Solutions that was acquired by Medtronic in 2014. We had developed a new generation of neuromodulators for bladder dysfunction. You know, I hate to say we have no competition. That always sounds somewhat arrogant, but we have no direct competition. There is no device out there that works like CarePath works. Anybody from the business side on this webinar who's listening in understands that in order to be viable in the marketplace, to ever get true adoption, you have to have some way of arriving at reimbursement. Procedures, techniques, technology is not reimbursed, and healthcare has a long and difficult journey to survival and success. So that's kind of a brief capsule view of remote patient monitoring. Got a lot more detail we can get into. I'll first stop and see if you have any questions from those that are listening to this, to give me some direction as to what their interest is in terms of the presentation. I know we have people here from some medicine, some product development, some business management, marketing.
Tell us about the red asterisk there for reimbursable. Why are you?
Let me talk about reimbursement, because that's a very important topic. What I'm saying is, when we first began to develop the CarePath system, there was no reimbursement. All right. You didn't get reimbursed for doing voiding diaries at home. The reimbursement for
because there was no such thing.
What's that?
Because there was no such thing.
Yeah, well, you had the paper diary, and they would not reimburse for a commode having paper diary. Uroflows have reimbursement in the office only. So you'd bring the patient in, you'd have them in 2 or 3 times to get a Uroflow you could use. You would invest as a practice from the business side of it, over $100 or more in the time and overhead to get that one study done, and then you'd be reimbursed $12 for doing it. So for obvious reasons, it was not something from a financial point of view that was attractive to any practice. Now, in 2019, CMS began to really emphasize remote care, and they came in behind it strongly with a whole new series of codes under CPT codes just for remote patient monitoring. There's 4 codes, and those codes used across each study with the CarePath system generate somewhere around $175 for the practice. And it's under general supervision, which means that it doesn't have to be doctor time, it can be nursing time. So they may only have 4 or 5 minutes of their actual time spent in this process as a physician or a provider, but they're getting generous reimbursement in the process. And most of the patients that we deal with in urogynecology and urology tend to be older. They tend to be majority covered by Medicare. So they were covered by these CMS CPT codes. After COVID-19, we saw a change in telehealth adoption and acceptance that I thought would take us 5 or 6 years happen in 4 or 5 weeks. We've gone now to universal adoption and acceptance of all aspects of telehealth. So the payers have basically said, we're covering it. If you can do it at home and it provides any good faith information that helps in your management, we're covering it. So essentially now we have almost what approaches universal coverage by commercial payers for doing these studies at home with the CarePath system.
What you're saying is greater than 60% was a number that you wrote before a pandemic hit. What do you think the new number will be?
Well, I think now during
No,
the
it's
actual
speculation.
pandemic, I think after the, right now under the pandemic, and as long as we have the issue of COVID-19, it's probably well over 90% are covered. I think there'll be some slight pullback after we get over this in the next year or two, but not much. I think as there's been in place, the patients have adapted to it, the providers have adapted to it, and I think that it's kind of like, once the toothpaste is out of the tube, it's not going back in.
Mm-hmm.
And so I don't think we'll see complete pullback, just a small amount of pullback, and they may get more stringent on what they'll pay for and what they won't pay for. And we designed our system to make sure no matter what they change in it, we will still fit right in the middle of what they're looking for. The exact bullseye of what CMS has in mind.
Okay. From time to time, I have fielded questions for you, or I introduce the concept of the care path system, and someone will write me back and say, oh yeah, I know, back in some years back, I was at a trade show and I saw the toilet that does that, or they saw other attempts at what you're trying to do. Can you talk about what you learned from prior outings, and are any of those other products viable? Are they in the market today?
Let's talk about what's out there. And we have the paper diaries and plastic commodes, and they've been there for as long as I've been in practice or training. You have a few unconnected apps, which means if I'm doing a voiding diary now, I will have an app that allows me to input the input part, if you would, or to take the reading off of my commode head and put it in. Those are what I call unconnected apps, and they haven't really done much. They still rely on the basic weakness, which is the plastic commode hat.
Mm-hmm.
Okay. There is a system in Europe called Mincy. It relies on a plastic commode, but it's automated. So it has a scale in there and it functions as a Euroflow meter. It's a 3 or 4 piece system. You have to sort of build in your commode. It's not portable, it's expensive, and it doesn't solve the underlying problem. Is when we first started developing CarePath, we started off with looking for a commode solution, because that's a lot easier technology to develop. Problem is, we don't want to know what they do when I say go live in your bathroom for 3 days. I want to know what they do when they live their life for 3 days. So it's got to be portable. And the Mincy system, while it's interesting technology, is not portable. It doesn't solve the real issues of the information I want to arrive at. So that's the basic competition that we face right now. There's no direct competition. There's nothing really out there that is portable, accurate, can be used both in the home by the patient or any sort of ambulatory setting.
Would you talk about that toilet though?
The toilet, yeah, there's a Japanese version of that. The Japanese, if you've ever traveled in Asia, are really big on toilets, commodes. You get the ones that have like 85 different functions on the toilet seat. But they're very big on that. What they had was a system they developed many years ago, and it would basically measure urine output by measuring the level in the commode. So it was a whole commode built up with electronic sensors that would tell you how the level in the commode changed.
Mm-hmm.
And it would give you then output on as to their urine output and some idea in terms of volumes and flow. Now, there's a number of physiological reasons why that maybe is not a good idea. Never mind, it's not portable. Women and men, when they go to the bathroom, voiding is not necessarily all they do. Okay. And if they have a bowel movement at the same time, that's going to be counted as urine flow based on it. It's going to affect the volume in the system. So it had a number of shortcomings that did not suit the patient well. And plus, who's going to install a multi-$1,000 commode in their house for something they're only going to need to measure a few times in their life? So it was interesting technology. Maybe it has a place in your institutions like hospitals, but probably not.
Okay. I have to say a lot of interesting questions are coming in. My friend Jerry asks, what other ways can a patient's incontinence be diagnosed? Now, we've talked about Euroflows and we've talked about the commode hat. He says, and he asks some acronyms here, I don't know, but you will, be diagnosed such as SUI, UUI, and MUI, etc. Okay. What are those?
Yeah, the rest of these? Mixed urinary incontinence, stress urinary incontinence,
okay.
Urgency, UUI, incontinence. And what he's really saying is, how do you diagnose that? When the person has an incontinence episode on the phone app, all right, they enter the circumstances of the incontinence. So was it triggered by convenience, meaning they were walking by a washroom, they trained their bladder now to always try and be empty, so they go in and use it? Or was it based on activity? Were they active at the time? Were they cough or sneeze, and was that the reason that they leaked? Or was it urgency? Was there an urgency component saying, I gotta go, can't make it in time, and I'm incontinent? So the phone app has that information inputted by the patient when they have any sort of incontinence episode. And that's helpful to know. How else could you diagnose it without it? You ask the patient. But the problem is the bladder is a very poor historian. And patients don't always recall why they leaked. And so to try and get that information for a patient through questioning, you got some 75-year-old grandmother in front of you and you ask her, when did you leak? And they don't really have a clear idea of when they leaked. Some will tell you, yeah, I had to really go badly, couldn't make it in time, and that's what happens. Okay, fine. But some just say, I'm wet. I was wet at the moment. All of a sudden I was sitting there doing nothing and I became incontinent. So, that's hard to get from the patient. By entering every time they leak, we can get a clear picture, a trend of what is the main component here. Because they may have mixed, which means I have some urgency and some stress, and the combination of the two results in my incontinence.
I have questions from Lola asking, what does this cost?
The cost, as I said, is covered. The cost is $60 per study. So you may go home and you may use it 20 times, or you may go home and use it over 7 days or 3 days, depending on what the provider, the physician wants done. And the cost for all of that would be $60. Now, as I said, almost the majority of patients are covered in some fashion for it. So I think it'd be rare that any patient would have to come out of pocket for the $60. But 2 visits to the office, 2 co-pays, and you've reached your $60 anyway. So now we're doing it at home, in the convenience of your own home, not having to disrupt your day to go to the office to do it. So $60 is the cost of it.
Lola, my follow-up question is, did you mean cost to patient or cost to provider?
Cost to the provider, but they would then charge $60 to the patient. But the codes under the RPM codes covers it. So the providing of the equipment to the patient to use is one of those codes that's covered. So the nurse taking time to show it to you and the cost of providing it by the physician is covered by CMS on the RPM codes and almost all the private payers now under the relaxed reimbursement schedules during COVID-19.
What if, we've talked about it typically in terms of a urology practice. Can you see an entire hospital an entire hospital system adopting it and buying a fleet of these? And what kind of capital investment would that be?
Well, and that's one of the really dramatic things that's happened. When we went out the last couple of years, we talked to many hospital systems. One of the things you're running into is, we went to them and said, look, we have a problem coming up. You're already aware of it, but you as a healthcare system take care of patients with urology issues. And if you look at the number of urologists in practice and their age, 35% of those probably will retire in the next 5 to 6 years. Okay, 27% minimum at a time when urologists are already booked out for months and busy. At the same time, the population needing that care is going to grow by 22%. So you're going to run into a real issue in terms of being able to provide care. So we set up a system. We developed a urology telehealth program where it would allow them to use the care pass system at the community level by mid-levels to triage those patients, only the ones that really needed a urology specialist intervention would get to that point. And we could treat a good percentage of them at home and outside of that environment. So that's kind of one of the things we looked at. As we were talking to these different healthcare systems, they all got that. They all, 100% of them, this is the probably 20 largest healthcare systems in the country, including the VA. They got it immediately where the value of this was for them in providing urology care. But to a person, every single one said, we could use that in the hospital. Because when we go to the hospital and you spend $2,000 a day in a very expensive environment, and we have to do input, output, fluid balance charting, this is what they use. Very time consuming, very inaccurate. half the time it doesn't get completed by the nurse. She tries, but she can't do it. She doesn't have the time to do it, or it's inaccurate. So only 1 in 4 of those I&O charts, fluid balance charts, that they rely on for the majority of patients in the post-acute care area of the hospital ever get an accurate chart done. So they all said, we would like to look at using it there. And then COVID-19 hit. And now we have a whole lot more reasons to get the patient to the hospital sooner, reduce the nurse-patient contact points, and to also keep the patients at most risk, your heart failure patients, your patients with dialysis, to keep them out of that environment as well. So there's been tremendous demand for us to bring this technology into the hospital, into the post-hospital discharge environments for chronic care.
Let me spell out 2 things. One is we have been talking about the device as going home with a patient. And now you're introduced that we can take that same device and have it bedside at the hospital, and they could void in their toilet there as opposed to going to the toilet with a commode hat and the nurse has to come in and crouch and measure and write and pour and clean.
Yeah, write on a piece of paper, stick it in her pocket, and then go back at some point when she has time to put it into the health record.
Okay.
Yeah.
Second,
so it would be provided on the unit. It would be the post-cardiac step-down unit or the med-surg unit assigned to the patient, and that allows them to take their own readings. They'd have a phone app, they'd have the CarePath device, and they'd have their own ability then to do their own I&O, if you would, in real time. And then it gets over many of the problems that really cause issues now with that is, let's say they go down to visit somebody down the hall and they use their restroom, or somebody comes in to visit them and uses their restroom and the commode hat's still there. You know what I'm saying? Or they go down to the cafeteria, or they go down for x-ray. There's so many times the patient's not near their bathroom in those days that the voids, the voided voids just don't get done. And that's why only 1 in 4 is accurate and complete.
That's interesting. I didn't think about that. You're saying that the patient often leaves his own hospital bedside and is getting an x-ray and has to go, and then that doesn't count?
It doesn't count. There's no way of getting it. They don't bring the commode hat down to x-ray. They bring it down to the cafeteria. Bring it down. They want to go visit their family down in the lobby. Well, they're not bringing their commode hat with them. So basically, they use that restroom down there, and that data is lost. And that's why only 25% of the ones being done, despite all the cost and nursing time and effort, have any clinical value, meaning they're complete and they're accurate. And if you only have 1 in 4 that's complete and accurate, I, as a physician, don't know if I can rely on the numbers I'm getting back on the system or not.
Right. Right. That was the thing that appealed to me most about working on your project, that you are getting data that, oftentimes you're trying to guess, is this something surgical? Am I prescribing a medication? And I'm basing this on basically a guess based on whatever. I don't think this is as intuitive as you think. The patient comes in, has a urological complaint on the 9 o'clock part, and at 12 o'clock, we're seeing that the mid-level provider, that is, so are you saying that a nurse practitioner can take care of a lot of the easy stuff? Is that
they're coming in and they're mid-level and the person has bladder complaints, and they need to say, this is a person that I need to send on to a urologist, or can I take care of them here? Because many times these clinics, we're doing one for Vanderbilt, and they have 24 clinics around Tennessee, involves a drive. Involves a real effort to get to the urology clinic. So they get this exam, they do some simple lab investigations, and then do CarePath, either a uroflow and voiding diary or whatever. And that information would then allow them, along with a care pathway that tells them, what to do with each of those pieces of information, allow them to say, what, this patient comes in and they have overactive bladder, it's not obstructive due to their prostate, and we can treat them here. We can put them on bladder training or fluid management or lifestyle changes or medication and see how they do. If in 6 months on the OAB medication, they've gone through 2 medications, they're not getting better, okay, we'll send them on to the urologist. Or same for the person with BPH.
Mm-hmm. So you're saying that 40% of the time they get enough information from using the CarePath system that they don't need to bother the urologist ever?
Yeah, about 40% of the time we can keep those patients being cared for at the community level. And when they do arrive at the urology clinic to see the specialist, all of the information that they need to make a diagnosis and manage, they're going there because they're not straightforward, they're not simple. And so they need intervention of some sort, either invasive investigations or invasive therapies. Well, if I get there with no information, I got to start the whole process over again. But if I get there with CarePath, I can go back and look and see what's been done and how they've improved or not improved. Then I'm able to make that first visit a decision visit, where I say, okay, I've seen your data, I've seen where you've been, and now we're ready to talk about going to third-line therapy, which could be Botox of bladder or an implant for sacral nerve stimulation, or some sort of prostate surgical procedure to fix a obstruction problem secondary to BPH. I can make a definitive visit from that visit, and the patient doesn't have to go back through all the same investigation hoops I went through before. So there's a coherency to it that makes it more efficient for the patient and doesn't take a lot of the urologist's time in visits, investigations that can be done at a community level.
Thank you.
I have one slide I prepared, I'll throw it up there because one thing I want to talk about is teleurology. That was an easy slide to make. So this is teleurology today, all right? Now, if I put up congestive heart failure, I'd be showing you pulse oximeters, and I'd be showing you blood pressure monitors, and all sorts of automated remote patient monitoring technology that we have in place to take care of that person with congestive heart failure. Urology, we have nothing. Until now, that's right. We are working with some of the leaders in urology across the country and working with them to develop a true program, a teleurology program that gives the guidelines and the protocols for instituting a complete solution for these patients under teleurology. And we're working hard and fast to get it done before the second wave of COVID-19 arrives next year. So that right now, you have to understand from the provider point of view, the majority of urology practices in the country shut down during this. They've seen their revenues and their patient volumes drop by 90%. They've had to lay off staff, lay off key people in their practice because they just couldn't practice.
I didn't think of that. I mean, I know that my dental checkup has been indefinitely postponed.
Right.
Urologist is getting my.
Yeah, we have people working for you. You have people, you have mid-levels and nurses and schedulers, and a lot of them have been let go. So it's going to be a very slow road to get back to a point where they're functional and efficient and running back with the kind of volumes that get the people seen in a reasonable time frame. But we face going through this again next year.
Okay.
And it's our goal to get something in place so when it happens, we can at least maintain a viable practice. We can get patients taken care of. Maybe we can't operate them on them electively, but we can get them through the process of diagnosis, initial management, so then we can do surgeries. We don't spend 3 or 4 or 6 months getting them to that point again.
Lee asks, do you have any kind of system or software development kit for interfacing a device to another piece of equipment that you're working in? How easily can we integrate this into other systems and platforms, the data that you're collecting here?
And this is a question that comes out of the conversation about putting it in hospitals or putting it in CHF teams and things like that. And I'm sure the person asking the question knows there's a number of API platforms you can use to integrate that data into the current hospital IT structures.
With which you're compatible.
Yeah, we will be. Now, one of the things we've done, and this is really based on the demands of COVID-19 and repeated requests from a number of healthcare systems, we've created a whole separate company that's just going to deal with the hospital and post-acute, post-hospital discharge need. And we're developing a system now, and it'll probably be 3 or 4 months to finish it, that will do that will allow us to interface in that fashion. In terms of the office-based system, it's not the same critical need. They can go online. We have an online. They go online, pull a report, put it in their EMR. That's not the same problem. But in the hospital environment, it's far more strict, far more regulated. So we are working on that now. The answer to the question is, we will have that capability. It will probably be 4 to 6 months before we can implement it. We're setting up pilot programs in several of the major hospitals in the country to study it in real time, in the real environment, with a hope that we can get it launched on a broader scale before we get, the COVID wave next year.
Gilles asks, do you have any details about accuracy of uroflow measurements in comparison with current in-hospital uroflow. I've never been able to pronounce that properly.
Uroflow. Yeah. In terms of accuracy, and this will be a very quick bit of physics. When we measure in current technology, the current uroflow meters, they measure weight, and the weight measurement is susceptible to a number of inaccuracies that are just inherent in how it's being done. So if you were to take a uroflow meter, for instance, and you were to sit in a commode chair or void into it, you're dropping that urine probably 30 centimeters, okay? I want you to think about getting up in the morning, going into your bathroom, and hopefully you have a non-digital scale that has a dial with a needle on it. If you step on that scale, you know what happens? You step on it and it jumps 30 pounds more than your weight. It comes back to where it should be. That's because of the impact of taking your weight, your mass, and moving it through space and landing on the scale. Now I drop the urine 30 centimeters, right? That's like you stepping off a chair onto your bathroom scale and seeing what happens to the meter, okay? That falling urine weighs more on the scale than if it just was in there already. And that difference becomes very hard to work out. And plus it hits the funnel, swirls in the funnel. The urine stream is not consistent as to when it goes through the funnel. All these things build up an inaccuracy in it. And it's plus or minus 15% or more on a standard uroflow meter using gravity and weight. Our system is based on volume, measured directly at the urethra almost, if you would. And so our accuracy is probably plus or minus less than 6%. So inherently a volume-based system is going to be more accurate than a weight-based system. Now, does it matter clinically? That's the question. They do a lot of software manipulation on a standard uroflow using weights that bring it back into some sort of functional range. So except for the few patients that are right on the edge of making a critical decision and the flow rate may make that difference, in most patients, I don't think it matters clinically, but your volume-based measurement is always going to be more accurate than what you can do with weight-based.
Could you show us the slide that has the, you blow out that section about the insides, how it works?
Oh yeah, the technology is not sure.
Yeah.
That's tech. So basically how our system works is we have a flow-through system. It's not being stored in there. It basically is a flow-through system. So we are able to have a float arm here, and at the axis of the float arm, we have a small magnet. And then we have a rotary Hall sensor, which is able to determine the exact orientation of that magnet in space. So if you look at our device here, here's our sensor. There's no contact points here. And it measures the exact position of that magnet. So as the float arm here rises in the urine, it changes the angle back here. And we're sensitive to 1/100th of a degree change. So we know coming through.
You said that it matters how you hold the device?
No, it doesn't.
Oh.
It doesn't because the accelerometer is built in a handle.
Okay.
We know exactly what the position in space is in terms of pitch or roll. And so we know exactly how that affects the level of fluid in the bucket. And we know exactly how fast the non-compressible fluid comes through the outlet.
Would you
so knowing all of that, what's that?
Would you put the bucket on the handle so we see? Show us how you do that. Up, because we can't see.
Okay, see? It clicks on there. There's an RFID chip in each one, so we know each one's unique. So as it flows through here, we know exactly what volume is in the bucket. We know how fast it's coming out of the bucket with accuracy. So we can calculate how fast it's coming in. It's simple math then. And that's how it measures it.
I smile because I think that's genius. Mahr asks, is this a DME device? If so, how is that part covered by Medicare and commercial?
No, it's not a DME device. It's not a durable medical equipment device. What it is a device covered under the RPM code, meaning that CMS says, we understand you have a cost as a provider in providing this equipment. We're going to cover that cost. And that cost, if you go under reimbursement, is we're going to pay you $62.44 to provide it. And we charge the physician or whoever is charged $60 for it. So it's covered by the codes under the RPM codes, remote patient monitoring codes. Now, reimbursement is a complicated area. Anytime you get a new CMS code, is very complicated. So we used probably the leading company in the country, PYA, to analyze everything we've done and everywhere it's going to be used to make sure that we stay compliant with the codes. And they have followed us for the last 2 years during development to make sure that we stay within the boundaries of CMS compliance. So it's fully covered under there. It's not a DME. So the patient doesn't go in and say, I want to buy one of these and take it home for myself, because the only value in it is the information generated that the provider, that the physician, the mid-level can use. So by itself, it doesn't have function to the patient. It's something the patient has to use to provide that data, onboarding data, to the physician to make decisions.
Lola asks some follow-up questions, and they're mostly about accuracy and testing, and have you done clinical trials? How sure can we be that you are at least as good as technology that's out there today or better?
Yeah, we're better than them. And what we had to do in order to do that is we had to set up a bladder lab. We have a bladder facility set up. We have a computerized, we have a slide somewhere on that if you can find it, where we set up, and we have a computerized platform that can both roll and pitch, okay, based on a computerized input to it. And we can then vary the flow through a very high precision flow pump. And this allows us to create an infinite series of uroflows. Basically, we can create unlimited number of different uroflow patterns. And we can measure then what our device measures in all the situations versus the absolute measurement. And that's how we know that we come within 3 to 4% of that. You can't clinically test it to find that out. It has to be tested in a very specific lab system. So we have maybe run 10,000 plus more runs on it with unique uroflows against an absolute standard measurement that we know is plus or minus 0.001% to understand the accuracy of it. And then we run it repeatedly to get the precision of it. And that's how we arrive at the information saying, yes, we are more accurate than what's out there currently on the market.
You're one smart.
But that whole project by itself, that whole setup to be able to test it and prove that point became a whole project within a project.
I'd like to ask, as we almost wrap, for the folks on the phone, type in a number from 1 to 10, 10 being this is the best thing to happen to urology, and 0, I can't believe I just wasted an hour with Dr. Brent Lang. How excited you are about this concept. A couple more questions coming in, again, about investment and cost. Yeah. How much would a urologist in an average practice need to, they say, hey, I'm in. How much would they need to spend to get started? How would they do that?
Yeah, the entire system, charger, tablet, everything installed with the handles to do their practice is somewhere around $6,000. The average, you're going to figure that if you look at the average urology practice, they're going to do somewhere around 1,000 studies a year would be what we would figure. And they're going to get reimbursed somewhere around $200 for that. So even if they do half of that, they're going to be somewhere between $100,000 to $1,000 that they're going to generate every year in revenue from the use of the system. And so the initial cost is $6,000, and then they spend $60 in each bucket. So from each study, they're probably going to be netting somewhere around $120 to $140.
And I'm, of course, not in the space. How many patients would a urologist see in a month?
Well, they're going to see between 1,200 and 1,500 new patients a year. 80% will have LUTS symptomatology when they arrive. And of those, probably 2/3 will have moderate to severe symptoms. I mean, they really need to have these investigations be done by that uroflow. So from those numbers, they're going to need more than one, because you do one in diagnosis and one or two in management.
Well, I saw that the system has 4 handles per base.
Per charger. Yeah, on the charger base, but we would give them as many handles as they need to make sure that their patient volume is being covered.
So if I give you $6,000, I get one charger and how many handles?
12 handles.
12 handles. Okay. All right.
And we also just understand, because we built an RFID chip into the handles. We know how often the handles are being used. Mm-hmm. So let's say that I have 8 male handles and 4 female handles for my practice. We can quickly tell in real time if we're overusing the male handles. You're running out, and we can then say, fine, we'll send you some more.
Okay.
So we can, so that we titrate, we adjust your volume of handles to your patient load on an ongoing basis.
So far, your average score from the response, I'm actually not going to tell you yet, so others can vote without a bias. You are not yet in market.
We are in market. No, right now we're doing a soft product launch. We are in 5 sites. And we're basically at this point, what happened with the COVID-19 affected everything. So, practices basically that we were set to install and basically shut down for 3 to 4 months. So it sort of delayed our ability to launch in those practices. But we're in Boulder, we are in 2 sites in Tennessee right now running patients through it. And then we are scheduled to install a number of more sites, probably give them time to recover, get back up to practice June, July.
Okay.
And that basically that point constitutes what we call a soft product launch. That lets us get out there, test several hundred patients in several different locations,
Okay.
including Vanderbilt University, and make sure that everything is working exactly the way it should, and we have all the supply chain set up to be able to then expand from there.
What are you looking for in terms of, are you accepting investors? Are you looking only at strategics? What kind of capital need do you have right now?
We are fully capitalized until the end of all that process. We have been approached by a number of investors who are interested, and it's what's changed for us is the COVID-19 pandemic, because it's put an urgency to it that didn't exist before. And so our plans.
It's increased your valuation?
I'm sure it has. I'm sure that the financial crisis has not helped it, but certainly the interest in telemedicine, remote patient monitoring has never been higher.
Are you aware of anyone else working on anything remotely competitive with what you're doing?
I'm not. It's a small world in terms of being involved in this particular space, and so I'm pretty sure I would have been. And plus, the patents we have in place, and the ones that are now pending as well, that's in 7 countries. That's the EU plus 6 other countries in the world. Really create a wall that's very, very hard to get over. If it's portable, if it's handheld, if it transmits data, it's basically patented under our patent. So I think competition is going to be extremely difficult in terms of trying to design around what we've already done. But I'm not aware of anybody at the present time working on anything that would be directly competitive to what we're doing now. There are a number of devices out there being worked on that work in the commode, or the device looks like a blender you bring home and it's used for Euroflows at home, and you set up on top of your commode and you void into it. They're not portable. They're not the same sort of comprehensive system that we're offering, so they're not really competitive in my view.
A not statistically significant sample of people asked how excited they are about your product say that they give you a 9 out of 10.
Oh my gosh! Thank you very kindly. Very kind. Thank you for coming in and attending, and I appreciate your time.